a great opportunity today. Typically, we'll talk to payers and talk to providers. We'll hear from payers, we'll hear from providers, but usually it's from a single point of view. And today, we're lucky enough to have a group of very knowledgeable, and from what I saw at breakfast, pretty outspoken group of CIOs here that represent both industries. And I think it gives us a great opportunity to kind of talk about how these two groups of organizations kind of evolve together, how they work together, and where the potential challenges and conflicts are as we try to evolve this whole health reform system moving forward. So I'm going to ask our CIOs to just briefly introduce themselves, and then we'll jump right into to the panel discussion. So Ken, would you start us off?
Sure. I'm Ken Gilles. My role is kind of a dual role. I'm the Associate CIO of Essentia Health and the CIO of the West Region. A little bit about Essentia Health. We're in the North Dakota, Minnesota area. We've got 3 regions across those areas and about 17 hospitals, 60 plus clinics, about 700 providers. And again, we cover that whole region, and then we've got actually some clinics and hospitals in Idaho that sort of kind of don't really fit the mix of where we have the other organizations, but kind of widespread in that area. So I think that's all I've got.
I'm Rich Kubica from Hartford Hospital in Hartford, Connecticut, and we're an 860-bed hospital, and we're the anchor hospital for the system. We have an enterprise CIO for the Hartford healthcare system. We're a total of 4 acute hospitals. Total of about 1,500 beds, about $2 billion in revenue. We also have a behavioral health network, as well as VNA home care and a rehab facilities. So we provide care across the continuum. We have a number of PCBs that we own and affiliated with others, and we are in a pluralistic model between physicians owning some and collaborating with others.
I'm David Lewis. I'm with Deseret Mutual Benefit Administrators in Salt Lake City, Utah. We're relatively small as a health plan. We're sort of broad in what we do. As a full benefits administrator, we do not only health plans, we do retirement plans, defined benefit pension plans, 401k, life insurance. So for the constituents we serve, we do the full range of benefits. Obviously, taking care of the health plan is one of the larger ones. Our clientele have some relationship with the Church of Jesus Christ of Latter-day Saints, the Mormon Church out of Salt Lake. And because they have employees of various sorts across the country, we have members in every state in the country. We're heavy in the Intermountain area. We actually also run a small international division, which is a whole other topic. But we have about 125,000 members across the country. And so our relationship with providers is very different because of that breadth. And so as we talk about this relationship, we'll see it's a little different than the health plan is tightly integrated with the provider side, which we don't have.
I'm Karl Oldroyd, IDC Operations Director. I understand I got promoted to CIO. So that's not that I really wanted that, but I'm with SelectHealth as part of the Intermountain Healthcare integrated provider and payer group. We began in 1975 as an offshoot from the LDS Church, where they divested themselves of the hospital organization. We are currently about 23 hospitals. Our membership base is about 540,000 in the health insurance side. The health insurance side has been in existence since 1984. So.
Great, thank you. I want to thank all our panelists for joining us today. So, on reform, we're now in a model where all of a sudden the expectation is that payers and providers are going to work a lot more closely together. They're going to share data. They're going to work collectively toward reducing the cost and improving the quality of care. Am I off base being a little skeptical that these things are going to happen as easily and as quickly as we might believe? I think, there's some fairly significant challenges here. I don't know, Rich, do you want to kind of start us off?
I'll start us off, yeah. Since we're in the Hartford area, the Aetnas are there, United Health is there. We actually have been in some discussions with some of the payers to see what we can do to share data. I would say it's a very beginning stage. And I would, if anything, I mean, it's almost dangerous to say that because nothing at all may happen with that. But we are exploring it as we look at various reimbursement models for ACOs and trying to do care across the continuum. One of the things we talked about this morning was home care. Is how the landscape is changing on who's responsible and who's paying.
Yeah, no, and we'll certainly get to that.
Yes.
That's a great issue. Now, no, go ahead.
Oh, I was just going to jump in there too. We actually are with the North Dakota Blue Shield. We went through a fair amount of consternation in this process, but we are actually sharing our EMR data with them. Reluctantly at first, they actually built into our contract, if we don't, here's the penalties or the savings that we're not, or I should say the reimbursement we're not going to get. I honestly still don't know if it was the right thing to do. We get patient consent before we do it, but we have all the data, and now they have all the data. And not sure if it's the right thing, but that's where it's headed.
So Karl, within Intermountain, how's the partnering perspective there? How do you guys go about that?
Well, one of the things is that we've been able to share that data for quite a while. We've actually had that electronic medical record that started in 1968, actually, by Home Warner, and basically you've been pushing that process up to and making that happen. As we've been able to share in that, we've had great rates looking at the ability to affect the outcomes, like in diabetes in particular. We've made great inroads from that. So it's easy, but it's hard for the fact that you've got to be concerned about whether you are sharing the right things and not affecting a member, or even from a perspective of being considered a monopoly in an organization, because we have a very close group within the Utah area where we're basically the major provider.
Yeah, I would think that you guys probably have a somewhat different challenge given the geographic dispersion of your members. How do you approach the provider partnering or provider data share?
Well, like I mentioned, most of our folks go from Southeast Idaho through Utah. We have a fair presence in California, but probably 60% of our people through the Intermountain area. We do participate in regionalized things where it makes sense. So, for example, in the state of Utah, there's an organization called the Utah Health Information Network. And for a number of years, we have, in a competitive environment, sort of thrown away the competitiveness among health plans and providers that come together in the background to improve administrative transactions. Well, more recently, in the last couple of years, we've been working on the GWS network, our Health Information Network, where clinical data is shared among the payers and the providers. So we participate and do that where we can. We're very supportive of those initiatives. The state of Utah itself actually passed some regulations that you shall share data. And so we shall share the data.
So
Kim made a comment and said it was the right thing to do. I think we're trying to do what's the right thing to do. We're not doing it because of legislation. We're concerned about, some guy falls off his bicycle down in Moab, Utah, goes in the ER, they need to see his medical records from Salt Lake City.
Right. So a lot of discussion around, kind of the exchange of data. We seem to be spending a lot of time on integration right now. But the hope, I think, certainly behind the legislation and reform and a lot of these activities is that integration leads to innovation. Within your areas, within your markets, within your networks, is there a perception of where that innovation needs to come from? Does that need to be physician and provider-based in terms of quality of care? Does that need to be payer-based in terms of new kind of directions and programs to support wellness? Where do you guys see innovation coming from in these partnerships, and how do you perceive that moving forward in the market? You want to start, Sully?
All right, sure. We're looking at it. When you think about it, it's pretty basic stuff. It's patient navigation. It's tracking the patient when they go outside. The penalty on readmissions has us very concerned because you lose track of the patient more or less once he walks out your door. So we're trying to look at methods that we can change that model, that we can be more responsive to the patient. With meaningful use, you have to give them a copy of their data, but then how do you track them, make sure they're taking the meds? How do you engage VNA or home care situations? Those are the types of things where we're trying to look at innovation and what we can do in those areas to cut back on the readmit rates. Could be as simple as somebody calling them up, actually the caseworkers are becoming more prominent.
Right.
So it's kind of a workflow process change, maybe some technology in there, and they may help. But right now, I think we're looking at that workflow process change.
I think it's a little confused from the patient's perspective also. Who is their relationship for their health?
Well,
They have their primary care physician, perhaps, hopefully. They have a specialist they go to. They have their insurance company that has generally more of the data together because they're paying all the things. So where are they going to go to if they want to find out something about health? Will they go to the doctor's website or the payer's website? Who should be reminding the patient that they should be taking their medications?
But there again, if they change payers, which is very common practice, every 2 years is an average, even with the same employer groups. And so that's very hard to put that responsibility on payers. It's got to be collected and aggregated. And that really, we say aggregated, it really needs to be back to the responsibility of the member or the patient. They need to own that data. We need to find ways to facilitate that. That's where the innovation and the technology comes in. And you say, well, that's Big Brother. Well, but is it? That person owns it. You provide them the deal. They make a decision. You reward them on that behavior, and that's part of the wellness program. Give them devices that they can track. They know what the location is, and so that we are basically know what they're doing at the times. Track and say, they're in the gym. We know why their heart rate's going up. They're eating. We know they're at rest. We know what their heart rate's doing. We know the content of the blood. We have those capabilities there.
Right.
We need to make it cheaper and affordable. Give them the choice.
go ahead.
Well, I was just going to mention, just to your question about what's going to drive the innovation, I kind of just look at this at the high level. The risk is going to drive the innovation. So if the providers take on more risk in this process, the providers are going to have to get more innovative. If the payers take on more risk, they're going to have to get more innovative. And the third part of the equation is the patient. If the patient doesn't have any risk, they're not going to be a part of the innovation equation. So we have to somehow get that triangle of all three of those. I'm not sure what the right mix of the risk is, but the risk is going to drive us to do things different than we do today.
So we talk about, the patient, the member, the consumer, and we create these cycles with them as a result of how we do business. So a patient may change their coverage because they have an employment change or they have a benefit change. They may change their PCP because now they want to be in network on their new plan. And we have this kind of turbulence in the environment here where I think we keep coming back to, well, the consumer has to be responsible for the consumer. Are you guys looking at mechanisms to put that in place? I mean, Karl, you talked about some of the opportunities technology creates, but are you actually trying to turn that into kind of programmatic features of your plans? Are you trying to find partners in either the aging in place or the remote health or the telemedicine space to make those things a reality?
Yeah, I know we're trying, but it's very, very slow in the process to do so because it takes money to get there. And who's going to pay for it? Eventually the consumer is paying for this, no matter what. It's in some realization somewhere else downstream. If it's not through the employer, it's basically through some tax or government program that eventually comes back that we all pay for. So, it's a matter of taking the leap and getting there, putting the capital in to make this happen, and then looking for a change in the way where we fund it and support it.